Let us begin. Let us begin by welcoming everyone here to tonight's webinar, Pua's webinar, that's going to focus on egg freezing, on fertility preservation. And who else would we invite to speak about fertility preservation than our dear friend, Dr. Joshua Klein? Many people on this call, in this webinar, are familiar with the amazing and tremendous work that Dr. Klein does. And for those of you who are unaware, Dr. Klein serves as the medical director for Extend Fertility. He's in Premium Health. He really was one of the pioneers behind the whole egg freezing campaign and initiative that was brought to the world, and most specifically to our Jewish community. And just an amazing debt of gratitude and hakaras hatov to all the work that Dr. Klein does, and how many women he's helped freeze eggs. How many of those women have gone on to get married, to have their own children? I mean, it's really a very, very beautiful, really beautiful contribution that Dr. Klein has given all of us. So a welcome and a shalom aleichem and a thank you, Dr. Klein, for all of your work, for all of your friendship and your dedication to the Jewish people, to our community. So really, thank you very much and welcome.
Thank you so much. I'm honored to participate, and you are flattering me with your unbelievable introduction. It's definitely been an honor and a privilege to be involved with this story for the last 10, 15 years now. And I'm happy to help share some of my, I guess, experience and perspective tonight.
So let's start there. You know, there was a perfect segue. So let's start there. Over the past 10 years, you know, and even stepping back 15, 20 years, how have you seen egg freezing and fertility preservation evolve into what it was and what it currently is, what you're seeing on a daily basis, and the medicine that you are bringing to the table? Kind of what has changed? And if you could just give us a little bit of background of, you know, what is egg freezing? Why is it important? And then we'll take it from there.
Yeah, absolutely. I mean, I think probably the best way to talk through it is, to some degree, a personal perspective. I finished my training, residency fellowship in the year 2011, I believe it was. And then I took a job with a big academically affiliated IVF center. And day in, day out, you know, what I was seeing, of course, is the realities of what we know about reproductive biology, that the fundamentals have not changed, which is that modern fertility treatment, of course, IUI, IVF, has been phenomenally impactful and a tremendous boon towards being able to help people build a family when they might otherwise not be able to either start a family or grow a family, for all kinds of reasons, whether it's ovulation problems, hormone problems, male problems, anatomical problems. But as I sometimes refer to it, the sort of dark secret of IVF back in those days and still today is that for women who are in their late 30s or certainly in their 40s, even IVF does not have great success rates. No matter how great the doctor is, no matter how great the clinic is, it's universally very, very challenging to help women conceive if they're in their late 30s and certainly in their 40s. And so, like a lot of areas of medicine, the question becomes, if we don't have a great treatment, at the very least, is there something that can be looked at as a form of prevention? And along the way, and this is sort of what's going through my head, being a young doctor about more than 10 years ago, almost 15 years ago now, what's going through my head is that egg freezing, we know, is a technology that has been around a long time. The first baby successfully born from a frozen egg came from an egg that was frozen in 1986. So the concept is not that new, but in the 80s and 90s, the technology just wasn't there. There was an older method of freezing that some of you may have heard of called slow freezing, which basically the challenge of egg freezing in general is to successfully cryopreserve, to freeze the eggs without disrupting the cell membranes and the cellular organelles, when something freezes, it forms crystals, ice crystals, and that can be damaging to the cells. And so slow freeze was one approach. It didn't work very well. Around the year 2000 and then the ensuing 5 to 10 years, this newer approach called vitrification became the leading technology to be able to successfully and safely freeze eggs. And it made great strides. So in the old days of slow freeze, I'm talking in, again, the 80s and 90s, going into the early 2000s, if you could achieve 50, 60% survival of eggs, that was considered quite good. But with the advances with vitrification, people are starting to show 70, 80, and even greater than 80% survival rates, which was a huge step forward. So in 2012, the American Society of Reproductive Medicine issued a guideline that basically said there were enough studies that have been published demonstrating the efficacy of this approach that we can allow fertility practitioners to offer egg freezing as a method of fertility preservation without it being in the context of an experimental procedure. And that's really what jump-started, I think, the growth of egg freezing as an option that became mainstream, essentially, that something that we can really look at patients and say, if you're not ready to be pregnant now, and you are trying to increase the odds that you'll be able to have children at a later date, this is something that, there's no guarantees, but this is something that can seriously offer you a real opportunity for success in the future. Whereas before that time, there wasn't anything that could be offered to women who weren't ready to conceive now, but were planning for the future.
Right. So let's go back to a basic overview of a woman's reproductive capabilities when she's even in utero to her, teens into 20s and 30s. And if you could give us that background, but heading towards the $1 million question, and that is, in your mind, when is the right time for a woman to freeze her eggs?
Yeah. It is the $1 million question. So I think the way I would probably lay it out is as follows, and anyone who, I apologize if people have heard me speak before, if they've ever met me before, I sing the same song, but I guess that's hopefully a good sign that I'm consistent in what I say. The way to think about it, I think, is that there's no question that age is the biggest, our biggest challenge, our biggest enemy when it comes to fertility. It kind of serves as a foundational obstacle. As a woman gets older, her fertility potential declines, regardless of everything else, regardless of how healthy the hormone balance is, regardless of how healthy the sperm is, regardless of how healthy they are in general. Age is sort of the elephant in the room issue when it comes to fertility. Why that is? Well, one thing I always emphasize to patients is that the statistics of successful fertility are driven by the age specifically of the eggs. So for example, if a woman is 45 years old today and wants to have a baby, so she can try. If she's not having success naturally, she might show up in my office and say, can you help me have a baby? And I'd say, well, you're 45, that's not the easiest time, but we can do IVF. We'll hurry up, we'll get started right away, and we'll do our best. Hopefully we'll give you the best chance we can. And then she might say back to me, well, before I sign up, I've heard it's not an easy thing. Can you give me a realistic sense of the chance of success? So like I said earlier, regardless of how great I might be or the lab might be and so on and so forth, the chance of success for a woman doing IVF today with her own 45-year-old eggs is going to be something south of 5% success per attempt. So not 0 and not 1 in a million, but pretty discouragingly low. But then if she says to me, wait a minute, I just remembered, that doesn't sound so appealing, but I just remembered I have this friend and she's in her 20s and she told me that if I need to, she's not planning to have kids, she'll give me some of her eggs, right? She'll give me some 25-year-old eggs and I can fertilize them. That's a whole other topic, but just to give you to bring out the concept, if we fertilize those younger eggs and then take that fertilized egg and put that into a 45-year-old person, what is the chance that that succeeds? The answer is very much higher. So 50, 60, maybe even 70% chance per try, pretty much the same as a 25-year-old is doing IVF in general. And so the idea being that the statistics of fertility follow the age of the egg, not so much the age of the person. I don't want to say the age of the person is completely irrelevant, but it's not a significant driver of success. And so the obvious key point then is that What's changing about a woman's biology as she gets older, the reason why fertility declines is because the eggs are changing. And then the question becomes, okay, so then what is it about the eggs that are changing? How are the eggs different at 45 than they were at 35? And how are the eggs different at 35 than they were at 25? And there, what I always talk about is that there's two aspects of the biology that are changing over time. Half of the story is egg quality, the health of the eggs, and the other half of the story is egg quantity, the amount of eggs remaining. And both of those are independently important concepts, and they tend to run in parallel, meaning both of them get worse over time. But there are specific details where there can be an exception, where you can have low egg quantity but still good egg quality, or vice versa. And so, without getting too far into that topic, just to kind of circle back to the question that you're asking, what is the right age to consider this? Inherently, fertility preservation is a proactive concept, meaning it is something that is done in advance of the problem to try to prevent the problem from overcoming us, rather than as a treatment or a repair for a problem that's already there. And so, of course, what that implies is that the time to freeze eggs is when they're not so bad, right? Before they get so bad. And the thing is, there's no magic number or age by which, before that age, everything's fine. And then you have your birthday and then the next day, everything falls apart. That's for sure not the way that the biology works. But what is true is that because there's a double whammy effect, meaning because you have both egg quality and egg quantity diminishing or deteriorating with time, it accelerates. So that women in their late 20s and early 30s usually are pretty good on both fronts. But that changes pretty rapidly, because as a woman progresses through her mid 30s into her late 30s and then 40s, both the quality and quantity are diminishing. And you have this sort of acceleration because both aspects compound each other. And so I'm being very long-winded. When it comes down to, we say, okay, that's really nice, and I'm glad you explained all that, but like, what's the age? So I think I'm fearful a little bit of giving a specific age, because it's going to also be different for different people, and I really should expand that in a moment. But as a general starting place, it's probably somewhere in the early to mid 30s, because that's when for most women, what we could get from egg freezing is still quite good. You might say, well, wait a minute, why don't we do it at age 21 when everything's super great? The answer for that, of course, is because if you're 21 and you're thinking about this, the gamble you're making is that maybe by the time I'm 23, I'm going to be in a position to start my family, and I'll have 5 kids by the time I'm 33. And so, we don't think that it's appropriate that every 21-year-old just goes the first thing they graduate from, from schooling and go freeze their eggs, because that's probably it won't hurt, although it'll hurt people's time and effort and pocketbook. So too early is probably unnecessary on a wide scale, but too late would be probably, not that it's too late, but suboptimal is already by mid to late 30s and older. It's certainly not as good as it was before that. And I'm happy to elaborate a little bit further, because there's that important point that I made, that not everyone is the same.
Right. I think it's important. A lot of people ask us, if a woman does a cycle of egg freezing, is that going to hurt their chances in the future of having children? So you said it doesn't hurt. So can you comment on that?
Yeah.
And also, if we could talk, because I know that there are women listening to this webinar who are in their, let's say, mid to upper 30s, if not 40s. So what would be the best recommendation? And then I see a number of questions are coming in. If you have some type of algorithm or some type of guidance towards, like, how many eggs do I need for the family that I envisioned? If I'm looking for a smaller family, I'm looking, I've always envisioned a larger family. If you could talk about, before we actually get into the details, because I know that that's one thing that I would like to cover tonight, just the logistically speaking, and the process, the procedure. What does it look like coming into the doctor? How to choose a doctor? And then what is the doctor going to tell me? What's my process going to look like? What are injections? Where do I get the injections from? All those types of things we definitely want to cover. But before we get there, if you could speak about, still kind of as a background, what does it look like for someone who is in their mid to upper 30s, if not 40s, and especially the scale of larger family, smaller family? How do you guide and support your couples through that? your patients?
So just to trying to make sure I don't forget any of the points, because there are a few mixed in there. So one
if
thing
you forget, I'm going to be the first one to
hold me
you
to it.
Forgot something, okay? You don't have to worry about that.
How much time do we got? No, so one question that was in there is, do we need to be nervous that, you know, if you do it and you don't need it, or even if you do need it, but does doing egg freezing in some way negatively impact future fertility, either natural fertility or anything else? So that's an easy one and a convenient one, because the answer is no. And that's actually been studied. If a woman goes through the process, does the medications, gets eggs to grow, we take the eggs out, it does not accelerate the natural loss of eggs. Women who go through the process are not on average going to have a lower egg supply than someone who never went through the process. There's a specific biological reason that that's true, which I can get into, but I'm going to hold off for the moment unless someone really wants to know. But the main answer is that it does not diminish the eggs available later. It does not diminish the natural opportunity or ability to conceive naturally in the future. Now, the larger question that you're bringing up about women who are in their mid-30s or late 30s or even 40s, and, you know, to what extent is that a problem, or people often ask, am I too late? Am I too old to freeze eggs? So it's very much a sliding scale, meaning what I was saying a couple minutes ago is, if we say, what is the ideal time, or what is the point at which, you know, if we can kind of strategize, that we would say is not too early and not too late. And so that's the general idea, where I was saying for most women in their 20s, certainly until the late 20s, is probably on the early side and too early. But by late 30s, I was careful, I think, with my words. It's not that it's too late. It's just that it may be less ideal than if it was done in the mid or early 30s. And but I think I want to go one level deeper here, because it's hard to answer the question accurately without bringing in one more layer here. And this is what I was saying a couple minutes ago about how different people are different. Because now, I said before that there are two aspects of the change in eggs over time. One of them is quality, the health of the eggs, and the other is quantity, the amount of eggs remaining. Egg quality we think of as a universal characteristic, and it's driven by age and age alone. So every woman who is 30 has mostly healthy eggs in her reserves. Every woman who is 40 has mostly unhealthy eggs in her reserves, and every woman in her mid-30s has a mix. So quality is something that we know just based on age and age alone. And this comes up a lot, but people who are looking to test their egg quality, there is no test for egg quality. Age is the test for egg quality. But the other side of the story, egg quantity, is actually something that is highly individually variable, meaning it is true that on average, women in their 20s have more eggs than women in their 30s, and women in their 30s have more eggs than women in their 40s. But every day we encounter women who are, let's say, in their late 20s or early 30s, who are reproductively young with good egg quality, but they actually have a low egg quantity, typically for reasons that we can't identify. It's just the way God made them. Or vice versa, women in their late 30s or early 40s that actually have lesser egg quality because of their age, but they have, luckily, better egg quantity. Why does that matter so much for the topic of egg freezing specifically? Well, when we talk about egg freezing, as most, if not everyone in this discussion probably has heard of, we don't freeze one egg at a time. We don't want to rely on any one egg being the one that's going to turn into a baby. Now, all babies come from one. I came from one, and you all came from one. You can't take two eggs and put them together and make a baby out of more than one. But if we rely on one, there's so many ways that one might not work out. For one thing, it may not be a healthy one to begin with. We can't see that at the time we take the eggs out of the woman's body to freeze them. And even if it is a healthy egg to begin with, the technology, while I was saying a few minutes ago how great strides it's taken, it's far from perfect. Some don't survive the freezing. Some don't fertilize when you put them together with the sperm cells. Some don't grow into an embryo. Some embryos don't implant. Some embryos will implant and not progress onto a viable live birth. And so, unfortunately, there's a lot of ways things fall apart. So the name of the game in the topic of egg freezing is that it is a numbers game. We like to freeze a whole bunch of eggs at once to hedge our bets that at least one of them, and hopefully more than one, but at least one of them will do what we want them to do. And so how does that connect to what I'm talking about, the egg quantity idea? Women who have a higher ovarian reserve, a higher egg quantity, if we give them medications to get eggs, will make more eggs in one shot than women who have a low egg supply. So in other words, when people go through the process, there are women who do it and get 20 or 30 or 40 eggs at a time, which is a huge number, and that's a wonderful result. There are women for whom we struggle to get 2 or 3 or 4 eggs at a time, and that's a much more challenging situation. What's the difference between the 3-egg person and the 23-egg person? It's not so much what we do or which medications they take. The primary difference is actually their biology, their ovarian reserve. And that is something that we can individualize. And so bottom line, to try to pull this together a little bit, if we can do testing, and AMH, as many of you are familiar with, or maybe familiar with, is probably the simplest, easily available blood test to measure egg supply. It's not perfect, and there are exceptions, and don't interpret it on your own without somebody helping you figure out what it means. Just a number is just a number. But that said, women who have there are women in their late 20s, early 30s who test their AMH and it's kind of low. Even though they're still pretty young, they may want to proactively decide to freeze their eggs sooner because they know they're already going to be getting a lower number of eggs in an egg freezing cycle. And vice versa, for a woman in her late 30s or 40s, it doesn't mean that she can just, like, if she has a high AMH, it doesn't mean she has nothing to worry about because quality still matters, and that's age-based. But they're actually fortunate that they may get 15 or 20 or more eggs at a time, and they're actually in better shape for their age than the average person their age. So it really becomes this individualized discussion, and we can use testing like AMH to help someone figure out, is this a thing that makes sense for me? What would be a realistic expectation if I do it? Is now the right time to do it? And so that's why, to some extent, you can't sort of draw general principles that are going to apply to every case, to every person.
Amazing. Let's discuss. Let's take a regular case. We'll take a 33-year-old woman who is not yet married. She is on this call. She says, wow, egg freezing sounds like a great idea. So, but let's say she lives in Los Angeles. She's my neighbor. So as much as she would love to go see Dr. Klein, she's not traveling across the country to freeze her eggs with Dr. Klein. So number one, what would you recommend for a patient who's looking for a fertility center? What questions, what should be on her mind? And then can you give us a little bit about what she should expect once she makes that appointment? When she makes that appointment with the doctor, what is her consultation going to look like? What is her cycle going to look like? What's the procedure going to look like? And walk us through until she actually freezes those eggs.
Yeah. I mean, I think that those two questions, and maybe that's why you're asking them together, are really connected. Because one thing I want to emphasize is that, and again, sorry if it's obvious to a lot of people who are familiar with the topic, but you don't walk in the door and freeze your eggs that day, right? So by definition, the process, and it's going to be a little bit different depending on the clinic that you might be interacting with, but the process entails, number one, gathering some information, specifically things like AMH to help inform the conversation. Number two, a consultation with the doctor or the nurse practitioner sometimes to kind of go over what the specifics of that person's general health are, what their goals for their family, and what we know about their biology, and setting expectations for what they might get out of it. So the beginning of the process is information gathering and discussion. And so that's helpful I think to keep in mind in general. And it connects to the how do you choose, kind of how do you know where to go? Because I think that maybe we're one step ahead, but by definition, it's something that's a pretty sensitive, personal, and really it's the kind of decision you want to make where you feel comfortable. Meaning, you definitely, I think it requires some research to go to somewhere that has a good reputation, and I'll get into that in a second. But also, it has to be somewhere where you feel comfortable that they listen, that they communicate, that they project that they have experience and they know what they're talking about. Because if you're getting the wrong vibe, if you're meeting with a doctor and you feel like they could care less, they have 100 other patients in the waiting room, or if they're so excited because you might be their first egg freezer that year, neither of those is probably an ideal scenario. And so you definitely want to listen to your gut when it comes to that type of that type of fit. And patients know themselves. Some patients have a mindset where I just want to show up. They tell me what to do. I'll take the medicines the doctor says. I'll be there on time, and just give me the marching orders. Some patients are going to do their Google research, and they're going to be wanting to ask 5 questions a day, and some clinics are much more available to answer lots of questions. Some clinics, they're happy to tell you what to do, but it kind of not much more than that, and it's okay. Different strokes for different folks, as they say, meaning there's going to be different cultures, and that's going to fit better for one patient or another. But the starting point, because I skipped over that, the starting point is that egg freezing is something that in this day and age, I'd say certainly 90+%, if not close to 99% of clinics, of any fertility clinic, is going to offer or generally offer. But there's no doubt that some clinics are going to be much more focused on it and have much more experience than others. And so I think that it's fair to say, if you're looking at different options for a clinic, you want to have some sense that they're comfortable and familiar, and it's something that they do frequently. There are clinics that do a handful of cases a year, and that may not be the best choice if egg freezing is what you're looking for. There's a very, very select few programs in the country, actually, that have published success rates of eggs they have frozen and subsequently unfrozen, and how much success they've had with their unfrozen eggs. Until this past year, I think there were only 2. At Extend Fertility, we just actually presented our experience with unfreezing our eggs a few months ago at the major national conference, the ASRM conference, and we're hopefully going to get that into a published paper sometime this year. But that's actually the most highest level of confidence would be a clinic that can say, here's our publication on what our success rate are. But to be perfectly honest, there's almost none that have, so that might be asking for more than you'll be able to find. But that's okay. I think that as long as it's a clinic that has a generally strong reputation and that does a significant volume of egg freezing and that you're comfortable with, those are sort of the primary criteria that you're going to be looking for when you start the conversation and again do the consultation and get a feel for the place.
Nice. Yeah, it's 100% true. I mean, PUA has calls every single day, and many of the calls are, what's the issue with me? Where should I go? Which doctor is best for you? And it's amazing to hear what people are interested in. Some people, as you said, all they care about. I recently spoke to a woman. She said, I really don't care about anything other than the doctor's bedside manner. What happens in the future is Hashem. She said, whatever happens, am I going to have a baby? Am I not going to have a baby? That's all up to Hashem. But I just need to go through the process, and I need to do it with someone who has amazing bedside manner, that when I walk in, he's going to smile at me, or she. I said, do you prefer a female or a male? Doesn't make a difference, as long as the doctor is nice and sweet and understanding. Again, the results are in Hashem's hands, not the doctor's hands. It was such an interesting perspective, and it goes to show how you have the exact opposite, where I don't care. The doctor could bark at me. The doctor could be the nastiest person. I want a baby. That's it. I want a baby. I want eggs. I want good eggs frozen, or I want a baby, whatever it is. I don't care about the process. And you have everything in between. So it's definitely an important point, and a really important discussion, whether to have it with someone like Dr. Klein or with PUA, to make sure that you are going to get the best care at the best facility. So patient decides they're going to go with Dr. Klein. They live on the East Coast. They're going with Dr. Klein. So they come to your office. They get that initial consultation. Now what? Once they're ready to freeze their eggs, what does the process look like?
Yeah, it's easier, I think, than most people imagine. Basically, we use the consultation as a sort of an educational visit, and then at that point, the patient basically decides is it something they want to be involved with or not. To go from deciding you want to do it to doing it, there's a little bit of legwork. Every clinic will have what they call a checklist of blood work, which is essentially the Department of Health requires that we have on file some basic blood tests, HIV, hepatitis B, hepatitis C. So there's going to be some basic blood work you need to accomplish. There's always going to be some form of a consent form. There's paperwork, and then there's medication teaching, because as many recognize, the medications that we use to cause multiple eggs to grow, like we said earlier, it's a numbers game. We want to get a lot of eggs, or as many as we can. The medications don't come primarily as pills. They come in injection form. And so one of the preparatory items is to learn about the different injections you'll need to use. It's not terribly difficult, but it is something that, is not obvious to most people, how to self-inject these kind of hormone medications. And that's another preparatory step. Once you get that accomplished, you're ready to do your actual cycle. Typically, in most programs, a cycle begins with a menstrual period. And we ask patients to let us know when their cycle begins. And then they come in usually the second or third day of their menstrual period to have a monitoring appointment. Monitoring is the term we use for ultrasounds and blood work to kind of check in under the hood, so to speak, to see what's going on reproductively, the hormone levels and what the ovaries look like. And we always do one to begin with before we start the shots to just confirm that everything looks healthy and normal to get going. Once that's accomplished, typically by the end of that same day, and again, every clinic is different, but this is some stuff that's pretty universal, you get a call from the office that says, okay, everything looks okay, you're going to start your injections tonight. The way most clinics do egg freezing, I'd say vast majority, the duration of injections is typically 8 to 12 nights of injections, plus or minus. So it's about a week and a half, never less than a week, not frequently more than 2 weeks. So the whole thing is relatively brief. So you're doing injections every night. It's typically 2 injections per night at the beginning, and usually it turns into 3 injections per night by the end. And during those 8 to 12 nights of injections, patients are being asked to come in for those morning monitoring visits, ultrasounds, and blood work approximately every other day. Every clinic has its own style, more or less, but usually it's about every couple of days. And that's how we see how the medication is working. Are there a lot of eggs growing or not a lot? Should we give more medicine or less medicine? Is it going fast? Are we ready to take them out yet? Or do we need to be more patient and let them give them more time? Once we see that the eggs have finished growing, we can then schedule the procedure to remove the eggs. That's called the egg retrieval. That's something that's typically done with anesthesia. The anesthesia is not technically general anesthesia, which would imply that there's a breathing tube and the patient is fully kind of paralyzed and anesthetized. But tachlis, practically, you don't feel anything, you don't remember anything, you're asleep. You're breathing on your own, but you're asleep. And the whole thing usually takes about 10 or 15 minutes. The way we take the eggs out of a woman's body, it's surgical, but it's not surgery. We're not cutting anybody open. There's no incision, there's no stitches, there's no scar, nothing like that. It's done through an ultrasound-guided needle. So the needle passes through the vaginal skin and directly into the ovary, and the needle draws out the eggs that have grown. And then people typically hang around the recovery room for maybe 45 minutes or an hour, and then they walk out on their own 2 feet about an hour after the procedure. So that's the kind of start to finish of at least the bare bones version of what an egg freezing cycle looks like. So roughly it's about 2 weeks, a lot of injections, a lot of morning visits, and then a procedure to kind of to close the deal to get the eggs out of the body and get them into the lab to freeze.
I just want to point out that PUA has a wonderful service that will connect you with a nurse or someone who can help you with those injections if you don't want to do the injections yourself. That's an important service that we've heard is really very helpful. Additionally, you mentioned that you walk out on your own 2 feet. So do people normally have some friend with them to help them, a family member, or can they really can they drive, or do they need someone to help them? And when are they going back to work? What is a person's like work schedule and life schedule look like during those 2 weeks? Are they like they're taking injections? Are they incapacitated? Are they are they having a hard time focusing at work? How do you balance your work life, your social life, and freezing eggs at the same time?
Yeah. So again, everybody's different, and so we warn people that it's a little bit difficult to predict. But I'd say the sort of typical or average experience. So most people continue their normal routine through the duration of all the shots and the monitoring. It's a little disruptive in the sense that if you're running to work early in the morning, I mean, most clinics open early. We open at 7 a.m. Every morning, 7 days a week. So usually, unless you have a very early, if you're, I guess, in healthcare maybe, or some other professions that are very, very early, for most people, you can get in on the early side and still get to work by 9 a.m. or whatever. So in that sense, it could be a little bit of a disruption to your work. But in terms of how you feel, for most people, it's not significantly disruptive to their everyday routine. The most common symptom during the medications, during the injections, is bloating, because basically there's a physical enlargement of the ovaries, and that's something that your body typically can perceive. So bloating is a very common, people call it a side effect. I don't know if it's a side effect or it's an effect, but it's a very common symptom during the time of the medications. There's a small minority of women who have other side effects of the medications, things like headache or nausea or feeling tired or feeling hot or cold or moody. These are hormonally type of side effects. I will point out that the hormones that we use to get the eggs to grow are not the hormones that are contained in birth control. Some people, they took birth control, they had a horrible experience, and they say, forget it, I can't take hormones. The hormones that are in birth control are estrogen and progesterone, synthetic forms of those hormones. The hormones that we give to get eggs to grow are the hormones that the brain makes to tell the ovaries to get the eggs to grow. They're not estrogen and they're not progesterone. And so even women who have had a bad experience with birth control they usually will tolerate the hormone medication to get the eggs to grow just fine. But again, everyone has their own experience, and some people will have more of a side effect issue than others. Bottom line, for the procedure day, we tell people that is the one day of the whole experience that you should plan to take the day off. At least in New York State, you're technically not allowed to go home yourself. It's mandatory to have someone to escort you home, because after you've been put to sleep, even for a short period of time, even for 10 or 15 minutes, you're not to be trusted to drive or be out in like the streets of Manhattan on the subway or something on your own, because you're still going to be potentially a little bit groggy and not yourself. So you're supposed to have someone chaperone you home. In the end of the day, we don't have people that didn't have a chaperone that are still waiting there, that we don't allow them to leave. We let them go, we watch them for extra time, and they can sign a thing and we can let them go. But ideally to have someone to take you home. And we ask you to take the rest of the day off from work. Definitely lots of people are on email or on the phone later in the day. We tell people the usual expectation is by the next day they can go back to school or work or whatever their normal routine is. Now, does anyone ever have to take a couple of extra days off? Yes. Everyone's different. Everyone's experience is different. Some people feel really more, run over by the whole procedure than others. And so I think you have to be aware of that reality, that it can be a little bit more than the average. But the typical experience is that you get to go back to your normal routine the next day.
Okay, you said something before, Dr. Klein, which if the Jewish ear was sensitive to it, then it would have a red flag would have come up. And you said that you're open 7 days a week. So can you talk to us and everyone here about that fear that we have, this desire to freeze our eggs, and we want to do it right, but we also want to keep Shabbos, and there's probably no other. I would not want to be spending my Shabbos in an operating room. So tell us about the balance between their fertility treatment and Shabbos. Is there a possibility there's going to be a Shabbos retrieval? Is there a Shabbos ultrasound, Shabbos blood work? Maybe talk a little bit about your Jewish patients, and then I'm happy to comment from the halachic perspective how Pua can help. But I really want to hear from your perspective, because you run the show.
Absolutely. So I was wondering if you're going to catch me on the 7 days a week, and you didn't disappoint. So most clinics do run 7 days a week. And of course, the reason why that's true is because the ovaries and the eggs don't know what day it is. And so things continue, Sunday is the same as Monday and Tuesday and Wednesday. But certainly there's a way to get through this whole process, recognizing that Shabbos is a different day. So I guess to start with, for monitoring, so as I said earlier, typically monitoring is happening approximately every other day. But that's approximately. And so, for example, if we see a patient on a Thursday, so if they're not Jewish or not Sabbath observant, they might say, okay, come back on Saturday for your next check. If it's a Shomer Shabbos person, and we try, and in our place, we do have a lot of religious patients, and obviously I'm religious. We have another doctor, lovely doctor, who's from as well. And there's just a lot of awareness in New York in general, and certainly in our place. And so we don't even think about it, we don't ask. If we know someone's from Shabbos, we're not going to say come back on Saturday, we'll say come back tomorrow. Now that's technically more than you need, but we'll look on Friday, and then Friday we'll make a decision if they need to do something over Shabbos, or they would just come back Sunday. So for monitoring, it's quite rare that we have a real issue to grapple with, where we really feel like we want to see someone on Shabbos, and then it becomes a question of if that's possible, how that's possible. But
if you do need blood work, so we have, Pua has a phlebotomist service. We send the phlebotomist to the house, take the blood, and deliver it to the lab, so that if the lab needs your blood, we can get it with a non-Jewish phlebotomist and take care and satisfy that. Have it all.
It is a tremendous boon to what we do day in, day out, to have that kind of service available. So because there are going to be days where we probably could get by without checking on Shabbos, but it really would be nice to get some information in terms of how things are progressing, and being able to just allow the patient to stay home and get a phlebotomist to go to the house, and the blood gets couriered over to the lab. And truth is, to me, this is like, people say, oh, what you do is like, it's like a miracle. I guess I'm privileged to do what I do. To me, the fact that we can get blood work with patients sitting at home on Shabbos, and all of a sudden in the computer, I also don't work Shabbos, so it's not me, but we see what's going on Shabbos. That's a miracle to me, that the blood shows up and we have the information.
Kudos to the non-Jewish phlebotomists that
exactly,
they take care of us.
It's the yes, the unsung heroes. So so monitoring is very rarely a real problem. Either we skip Saturday or we can get the home blood work, but that's almost never something that we really struggle with. In terms of the procedure, so starting with the idea that, again, the eggs don't know what day it is. So you would say 1 in 7 should land on Saturday just by chance. And that's sort of technically true, but conveniently, so the reality is that we do procedures, and every clinic is pretty much the same way. Procedures are done in the mornings because the lab then needs the rest of the day to process the eggs and to get them frozen and do the paperwork and everything. And realistically, the lab is not working through the night, so they want the eggs coming out in the morning, and then they do their thing for the rest of the day so that everyone gets to go home at a reasonable time. The truth is that we are, because of just the practicalities of life, that means that we have to choose the right day, and meaning it's either this morning or it's tomorrow morning. There's no option in between. When eggs grow, there's usually multiple of them. And the truth is some of them are a little bigger and some of them are a little smaller. So we're always kind of taking the whole picture as a picture and saying, as a group, we think it's better today or we think it's better tomorrow. But by definition, the smaller ones might have benefited for waiting a little bit more. The bigger ones maybe would benefit from being a little bit earlier, but we kind of have to just be realistic. And so taking that principle to Shabbos also, when we check someone and the eggs are just about ready on Friday, we say, well, we could say to do, or I should say really it's Thursday is the day that becomes an issue. We can lean forward and do the procedure on Friday, or we can lean backward and do the procedure on Sunday. Usually we're able to wiggle around to Friday or Sunday without compromising anything in any meaningful way or really in any significant way at all. But I will say that, and we do about 600 plus egg freezing cycles a year in addition to the IVF. And there are a few cases, a handful of cases a year where we really feel stuck. And we'll be honest with people. We say, really, Friday's going to be too early and we're nervous. Sunday's going to be too late. And you got to ask your Rav. And then it becomes a question of, is this something that can be done? We always happen to have a non-Jewish doctor in our practice on Shabbos. So that helps also, I think, Rabbi Siegelman comment on that and generally the halachic implications, but it comes up not never, but pretty rarely is the bottom line. Not 1 in 7, definitely much less than 1 in 7. Thank God.
Yeah, it's true. It is true. I mean, we could probably count on our hand, probably, or at least 2 hands, over the years, and we've been working with each other for many years. And on that note, I also want to acknowledge the presence of Rivki Itzkowitz, who's on the call. I see she's here. And Rivki Itzkowitz, who is the head of supervision here on the East Coast, on the entire East Coast. Hashgacha, supervision, something that Pua does so well and for so many years. There's always that having supervision in the lab, overseeing the egg retrieval and then following those eggs into the lab to make sure that they're frozen properly with Hashgacha, with our seal, and they'll never be tampered with. So it's always an additional calculation. If someone's coming for Shabbos, we also have to make sure we also have our mashgichot from either staying in the city. We have a number who live in the city. So there's a lot of coordination. It's been done, and we actually have many women who are doing hashgacha on every Shabbos because, let's say there was an IVF during the week. Throughout the week there are checks, so we have hashgacha throughout the week, 7 days a week. And it's a big yesher koach to Rivki, who's here, for all of the work that you've done for many years. Dr. Klein since he was probably much smaller. No.
I think every time it comes up, I get younger. When I was in 8th grade, and then my
exactly.
parent, I think.
Exactly. But Shabbos definitely comes up. It's definitely a consideration. But I can say publicly that Dr. Klein, and that's it's a question that we get every week when a woman who's doing egg freezing or an IVF cycle and Shabbos is imminent and there's a question, and there's always a conversation that I'll have with the doctors to really explore all of the options. Is Shabbos really necessary? And I can say personally that Dr. Klein, when a patient tells me that they're Dr. Klein's patient, so then it's a walk in the park because he speaks the language, he understands it, and he's able to completely, allow for the patient's cycle to be either taking place on Friday or on Saturday, on Sunday, avoiding Shabbos and not compromising their health at all, or the success of the cycle.
I'll just throw out there, by the way, I didn't realize that Rivki's on this,
Yeah.
This Zoom.
You can take something back. You can take anything back.
I'm not taking anything back, but she's going to hate me for saying this, but Rivki is like the hidden gem, maybe not so hidden, of Pua for, decades at this point. She's like the camp mother. Any trouble, you're sad, you're worried, go to Rivki, she'll take care of it. She'll take care of it. She'll hold your hand and she'll work it out. So Rivki is someone that if you're looking for support, that's someone who is unbelievable.
Yeah, Baruch Hashem. A few more questions because it is getting late. So I have a few more questions for you, and then we'll try to look at some of the questions, the many questions that have been submitted. Eggs are harvested. Eggs are taken into the lab. Let's say the lucky number is 12. 12 eggs, okay? It's a two-pronged question. Number one, what happens to those eggs? Okay. And number two, is that number 12? The patient's going to ask you, Dr. Klein, am I good now? Am I set? Or do I need to do another cycle? Okay, you called me and you told me that I have 12 eggs. What does that mean? What does that mean for me as a 34-year-old single woman?
So the first part is a little bit technical, and I'm not sure if this is what specifically you wanted me to comment, but one sort of practical reality of the egg freezing, I kind of alluded to it before, is that some eggs progress more quickly than others. So usually you'll hear two numbers at the end of the cycle. One is the total number of eggs that came out, and the other is the number of mature eggs that came out. Mature eggs are the ones we want because immature eggs generally are not capable of being fertilized. There's technology that's being developed to help capture the potential of immature eggs, but in general, as a rule of thumb today, mature eggs are the ones we care about. So if you have 12 eggs, one thing you want to just verify, is that 12 mature eggs or is that 12?
Yeah, 12 mature eggs.
Yeah. So the eggs are frozen within a few hours of the egg retrieval after the process. So they're frozen before the end of the day that day. I don't think it's super important to get into the details of what happens in the lab. And the truth is, I wouldn't be the best person to explain it. But the long and short of it is that they process them and they get them into liquid nitrogen and they're preserved and they're sealed off with the PUA seal. Are you set? So, I said much earlier in this conversation, technically, all you need to make a baby is one. And in fact, you can only make a baby from one, right? So on the one hand, one egg should be enough. On the other hand, what we also said before is that there's a lot of reasons why one egg might not work out. It might not be a healthy one. It might not survive. It might not fertilize, and so on and so forth. So the best answer to the question is the following. The number of eggs that would be considered sufficient is going to be dependent on, number one, the age of the woman who is freezing their eggs. And that's because, and maybe it's obvious, but just to say it, if a woman is freezing eggs when she's 30, there's a higher proportion of healthy eggs that are coming out. And so, for example, the 10 eggs for a 30-year-old is probably more likely to work out than 15 eggs for a 39-year-old, meaning of those 10 versus 15 eggs, the number that are actually going to be healthy, usable eggs is going to be, from those 10 for a 30-year-old, it might be 7 or 8 or even 9. From those 15 from a 38-year-old or 39-year-old, it might only be 5 or 6. So that's a key piece of the discussion, which is partly why you have to have a conversation with the doctor or provider who knows you. And then the second part of it, of course, is what your goals are. Because what is a good number? No number is going to get you to 100% certainty. And that's a really key fundamental idea to just make peace with. There is no number of eggs that you can freeze. They have nothing to worry about. You can freeze 100 eggs. It's still, for one thing, by the way, the guys have some responsibility here too, right? So if you in the future are trying to have a baby with a guy who has a major sperm problem, it doesn't matter how many eggs you might have, you're still going to, God forbid, you could have major issues. So there's no number that reaches 100, and even one can work. And that's both really actually true. But as a rule of thumb, because I know that's not going to satisfy people for the most part, for women who are freezing eggs in their mid-30s and younger, freezing at least 10 or 15 eggs gives them a strong chance of success in the future. What does strong mean? Probably 60, 70, 80% chance of having at least one child from those 10 or 15 eggs. For women who are freezing eggs at an older age, let's say between 35 and 40, ideally, to get that same 60, 70, 80% chance, you're probably talking about between 15 and 25 eggs would get you to that same place. And for women who are 40 and up, as many as possible. 20 plus is probably really what you're looking at. Now, I'm always careful when I say that, at least to an individual, because for someone who's 42 and says, okay, you need 20 or 30 eggs, and she, knowing her AMH, she may only get 3 or 4 eggs at a time. That is a hard thing to process and may not be a very helpful comment to make. Oh, you really should have 25, and you're going to get 3 at a time. So I think it's always important to emphasize that we all do our best, meaning whether it's 5 or it's 25 eggs, whether you're 25 or 45 years old, no one's guaranteed it's going to work. No one's guaranteed it's not work. 1 egg can work no matter how old you are. And so it's something that you kind of have to figure out, and I think talk through with someone who knows this topic and also knows you. Some people are doing this as a last ditch, my friends all did it. I don't plan to I'm going to hopefully get married next year or 2. I don't plan to use these eggs. It's just nice to have. So for that person, they might freeze 5 or 10 eggs, and it's a nice thing to have in the back pocket, but they're not so serious about it. Somebody else, they feel like, for whatever reason, they're not going to be able to have children until they're 40, and they want to have at least 3 children. They need to have a lot of eggs lined up, and so it really becomes this personalized cheshbon, personalized calculation of what is a good number of eggs to have. So it's really difficult to oversimplify it, but I tried to give some rules of thumb, I guess.
Yeah. A few more questions that are, Baruch Hashem, there's a very active group here on the chat and in the question and answers. So I really want to try to get to all of them, but there have been a few questions that have come in about discarding unused eggs or unused embryos. Should those eggs become embryos? They get married, sperm is now introduced into the mix, so they're able to thaw those frozen eggs, right? And I think it might be important. It might be important just to make it clear that women who are freezing their eggs, the way that they get pregnant with those eggs is through an IVF cycle. Meaning, once you freeze those eggs will then be used in an IVF cycle. They're right.
Correct. Yes, you can't put them back in and go home and get pregnant.
Right. So and that means that when let's say this woman gets married, she now has a husband's sperm. She has 20 eggs. Let's say she has 5 or 6 or 7 healthy embryos. Now they really only want 2 children. So let's assume that, we'll give her the greatest possibility. She gets pregnant with the first 2, and she has 4 leftover embryos, and someone else has eggs that she's never using because she got married and now she has her children naturally. So I guess people are asking from a halachic / medical perspective. What can you talk to us about, like, what happens to those eggs that aren't used? And then I'll comment on the halachic, but
yeah,
what do you do? What that's definitely a concern here.
Yeah, it's a concern. It's a growing concern. Thank God, as the technology gets better, we get more eggs, we get better at using those eggs, using those embryos. It's going to become, honestly, more and more of a concern. The main principle that I think is important to emphasize from the medical perspective is this is your stuff, meaning we might be storing it for you, and typically there's like annual storage fees, but you are the boss of what happens with your stuff. So it is quite common, and I'll let you comment on the halachic side of things, but it's quite common for stuff to get discarded. Eggs or embryos are not children, I think it's fair to say in the view of halacha. So discarding is very common, even amongst frum people. Could you potentially give that egg or embryo to somebody else? That's a very complicated, heavy conversation that isn't simple at all, but if that's what you chose to do, there's a way to do that from a medical perspective. We also have had patients who, because we've had some partnerships with research institutions, that they'll donate their stuff for the purposes of science, meaning to further research, or for the purposes of training. And again, that's a halachic question to ask. But bottom line is, those are really the options: is discarding, giving it to somebody, donating it to research. But whatever the bottom line is, you tell us. You're the boss. It's your stuff, and we don't do anything to your stuff unless you tell us to do it.
Yeah, and Dr. Klein, you mentioned correctly that halacha doesn't view even a fertilized egg as a life. Life begins when that egg is implanted in the uterus. Prior to being implanted in the uterus, it is not the status of life. Discarding it is not terminating it. It's not an abortion. Should all of the electricity go out in a fertility lab on Shabbos, chas v'shalom, there would be no heter to break Shabbos, to have a Jewish person drive to plug the tank back in. That would not be allowed, because we were only allowed to do that for a life. We're only allowed to save life, pikuach nefesh, and we would not be allowed to do that to save an embryo because it is not life.
That's why we have non-Jewish embryologists and backup power.
Yeah. There was a very important question, and that was, how does obesity impact fertility in general? But let's say for this conversation, we'll speak about egg freezing. Should a patient take the time to go on, let's say, weight loss drugs or medication to then, although they'll be a little bit older when they will now revisit egg freezing, but at least their BMI will have gotten smaller. They will have lost weight. Can you speak a little bit about that conflict? Weight?
Yeah, that's a very common issue for sure. So there's a concrete level and then there's an abstract level. The concrete level is that, as we have already discussed, to get through the egg freezing process, it's the last step is going to be an egg retrieval procedure, which is typically done under anesthesia. Almost every fertility lab, fertility program exists in some non-hospital based facility, meaning an office-based facility. And so to administer anesthesia safely in an outpatient setting, almost every anesthesiologist will have some cutoff. If a patient is above a certain body mass index, if they're very, very heavy, very obese, they're going to consider that as an unsafe thing to put that patient to sleep because they're just a very high risk anesthesia candidate. So that's one thing that comes up all the time for patients that are significantly overweight is, are they eligible for doing the procedure under anesthesia at that facility? For patients who are up over the line and are cut off, I think it's 45 for a BMI. Some places are much lower. If someone is over that line, then they have two choices. Either they can go and try to lose weight to get into a safer position, or with discussion, depending on their mindset, this procedure can be done with local anesthesia. It takes someone who's very motivated to be able to tolerate that because it's still uncomfortable, but it's something that at least we can talk about. So that's the concrete issue is, kind of a cutoff for BMI and the anesthesia. That is going to be a question for any clinic, and it's going to be a little bit different for any clinic. The abstract issue when it comes to being overweight is, does it have a medical impact on our ability to get the eggs to grow, to get eggs out? And the truth is that the main answer is not so much. We know that overall health does have some loose relationship with fertility health. And there's no doubt that there are studies that look at, for example, women who are doing IVF, where you have a much more specific outcome, they get pregnant or they don't. And there's an association between being a healthy weight and having a better chance of success with IVF. So it's very easy to support the notion that if a woman can try to optimize her physical health, and that includes weight, but includes everything else about physical health, eating right, sleeping right, getting some exercise, not smoking, not drinking heavily, all those kind of things that play into general health. It has some loose association with fertility health. But when push comes to shove, as you phrased the question, I think in a sort of potent way, if someone's in their late 30s and they say, look, I'm overweight, I'm gonna work on it, would it be better to do this now, or better to go work on weight loss and come back in a couple of years? The answer is do it now if you can, because the couple of years we know is a major blow, is a major hit to what they're going to get out of it. The weight issue is suboptimal, maybe a little, but it's not something that I think when you weigh those two together, I would certainly prefer that the patient does it now and doesn't, kind of spend the next couple of years on weight loss.
Okay, last question, saving the best for last. And it seems like, again, we're not going to get to all of the questions, unfortunately, but I'm happy to share my email. I can't speak for Dr. Klein, but here's the last question that I think everyone is antsy to know. And can you talk a little bit about pricing for this whole process? And if there are any programs that help, at least in the tri-state area, because I know many of our listeners are in that, insurance or tri-state area programs. Can you talk a little bit about that, please?
Yeah. So in a nutshell, I can certainly tell you what the numbers are at our program. It's going to be different at every program. We try to be pretty transparent. So if you go to the website for Extend Fertility, you'll see these numbers. With our program, it's 79. Actually, sorry, let me take a step back. There's three main costs that you have to think about. And of course, by the way, there are some very fortunate people who have some version of insurance coverage, either for the procedure or sometimes for the medications. Most people do not. Even if you have good health insurance, you probably don't. but it's worth at least thinking about looking into. And our billing people would help you figure out if there's any coverage. But let's assume for a second, like the majority of people don't have insurance coverage. So out of pocket, there's the fee for the actual cycle. That's one main cost. There's the fee for not fee, there's the cost of medications. The medications are very frustratingly expensive. And then there's the cost in a longer term of storage. Those are sort of the three main costs to be budgeting for when you're talking about egg freezing. So at Extend Fertility, the fee for a cycle is $7,900. That's basically what it costs to get your eggs frozen. For patients who do end up doing more than one cycle, they automatically discount it down to, I think, $7,200 for subsequent cycles. I think it's $7,200, something like that. There are places that are probably, I don't know, $5,000, but maybe $6,000 or $7,000. There are places that are $10,000 or $12,000. So that's going to be the neighborhood. We're somewhere sort of in the middle, hopefully on the lower side. Medications are going to differ by how much medicine you need, what your protocol is. But the low end of medication cost is like $2,000 to $3,000 for one cycle. The high end could be $5,000 or $6,000. So that's another very significant additional cost. That's usually not something that the clinic would be charging you, but you would be using a pharmacy. And then the third component, which is the smallest component, is storage. And again, there's going to be a range. At Extend, I think they charge $800 a year for ongoing storage costs. That's better, approximately what things should cost, again, within a range. In terms of being able to find ways to make it affordable. So for one thing, I'm quite sure that if you tell them that you're referred by PUA, they give you a discount. I think it's 10% right off the bat. So that helps. There are definitely ways to look into making it financed over time. There are companies that do it, and I think there's like the Hebrew Free Loan Society. And then there's grants. There are a few organizations that sometimes have grant money. I don't know, is PUA?
PUA definitely has, we have two different programs. We have grants, and we also have an interest-free loan. So I'll actually send in the chat, I'll send the email, gemach@puafertility.org. Spelled that correctly. gemach@puafertility.org. You can send us an email and look into applying for financial aid for egg freezing.
Thank you. I put my email in there.
One second. I'm going to send it because you sent it just to.
Oh, I didn't get it to everybody. Sorry. You can send it to everybody. If you sat listening to me for an hour, then you deserve to have my email. I will say that if you send me an email and we don't know you as a patient, write something like PUA webinar or something, so we know where the email is coming from, and then I may respond directly. I may have one of my colleagues. My email inbox is like a marble every day, and so I can't promise that I'll respond directly to everything, but I'll try. I'll do my best. But certainly I know that we're leaving you with a lot of questions still because there's only so much time. So if it's something medical that you would want me to weigh in on, I will do my best to be helpful.
Amazing. I think parting words, for such an informative evening. I think one of the most important lines that you said, Dr. Klein, was that it's really, I forget exactly what the words were, the exact words, but it's not overwhelmingly difficult and challenging. It may seem, for someone who hasn't done it, or for people who are exploring the options, it may seem very overwhelming amount in terms of the time, the physical, what you'll physically endure, the financial component. And no one's going to tell you that this is a walk in the park. But I think what you were able to do tonight, and hopefully the message we're able to share with the listeners, is that this is something which people are doing every single day, day in and day out. I mean, you said 600 plus cycles per year. People in our community, whether you're in the tri-state area, whether you're in Los Angeles, where I am, or everywhere in between, people are freezing their eggs. And it's a really important, at least a really important consideration. And conversations like this and information that you hear from Dr. Klein, I think for me, it enables us to just take that deep breath and to have the courage to go into, at least pick up the phone or send an email to PUA, to Dr. Klein, whomever it may be, to say, okay, what are my next steps? And really help, bring it to the finish line. I think there are a lot of people that have been thinking about egg freezing for years and years and years and years. And then the worst thing, Dr. Klein, I'll share with you what my experience, and I'm sure you have it way more than me, but the worst thing is when a patient tells us, why didn't anyone tell me about this earlier? Why didn't I know about this earlier? Why am I now, there's just so much regret and so much guilt and shame. And we never want anyone to ever utter those words. Why didn't I know? Or why couldn't I have done it when I should have? So being able to empower the community with this information, where to turn, to whom to call, where to, what does it look like? What does the process look like? I think it's an incredibly important opportunity. It's a schus for Pua to be able to host you, Dr. Klein, and to make this information accessible. And the recording will be shared with many more people who are not on the call. But those are my parting words, Dr. Klein. I'm happy to share the mic. Although I do want to say that someone just wrote, "I'm Dr. Klein's patient. He's a real mensch. Whoever needs his help." Okay, I couldn't finish the, but it's true. Okay.
I appreciate that. No, obviously, it's my honor to be invited to participate. I'll say one very concrete thing, which is that we looked at this data recently. We hadn't in a long time. I think it's just under 60% of women who walk into the office and do a consultation for egg freezing do it. And I don't know if that strikes people as a lot or little. To me, that's very comfortable. And what I mean by that is kind of picking up on the heels of what you just said, Rabbi Siegelman. What you don't want to do is kind of be overwhelmed, be scared, and run the other way, and then God forbid, regret it later. I think that you have very little to lose to kind of investigate the topic, get an AMH drawn, understand better what your situation is, what your story is. And then some people choose to do it, and guess what? A lot of people don't. And maybe some of them circle back a year or two later, and we've seen plenty of those. And some will go on and decide it's not for them, or get married, get pregnant naturally, and that's amazing. And so I guess that's exactly right. That the kind of take-home message, I think, is it's a subject that's manageable. It's not simple. It takes a lot of commitment, but it's definitely doable, and it's something that I think the worst is to feel overwhelmed by the heaviness of the subject, and then kind of not have the opportunity to make an informed decision if it's something that makes sense for your life or not. So get the information, get educated, and then not everybody has to freeze their eggs. That's okay, but don't miss out on an opportunity that might be for you just because it feels overwhelming. I think that's the key point.
Amazing. Dr. Klein from Extend Fertility, thank you very much for joining us this evening. Thank you everyone for joining us. And please feel free to be in touch with myself, with Pua, with Dr. Klein, and everyone should have bracha and hatzlacha in all of our endeavors.
Amen. Thank you so much.
Have a great night, everybody.
Thanks everyone for listening.